were going to, as of the 23rd of February, which is today, we have submitted our project plan application, and we last week completed the submission for the capital applications, and that was a huge amount of work for all of you and for all of us, and we're just very, very happy that that's behind us. We are now into the implementation phase for the DSRIP program, and, you know, we did not have a lot of rest after the application was filed. We are in full implementation mode, as you're going to see going along today. I just want to mention a word on scoring. You've all probably seen the applications have all been scored, and actually we did very well. We had a near perfect score in terms of the subjective part of the application, and this may not be music to your ears, but we had the highest score in the state in terms of the composite index, which refers to the level of complexity of the projects in aggregate that we selected. So thank you all very much for the input and the participation. And now we have set ourselves a bunch of very challenging goals that we look forward to meeting. March 1st, we'll start feeding pieces of our implementation plan to the KPG. They are then due to the state the detailed implementation plans by April 1st, and DY1 actually kicks off on April 1st. So we have learned recently that the monies will not flow until about the third week of April, and of course nobody has evaluation yet, so it's difficult for us to really begin to discuss absolute numbers. So having said that, now we turn to implementation. And there are 4 key elements to this that cut across all of the projects. And those key elements are governance, financial sustainability, workforce, and cultural competency. And with regard to governance, key issues that measures include community engagement. As those of you who've been with us from the start, we did community surveys, focus groups, and a lot of outreach, lots of meetings. Key area is workforce communication and engagement of the workforce, CBO partnership agreements, which will flow as the DSRIP DY1 begins, and also agency coordination plans are well underway. We are coordinating with the Departments of Health and Mental Health and have meetings scheduled with both the local health departments and OMH over the coming weeks. We have also will be establishing a PPS quality committee, which will be overseen by our fairly newly minted regional quality council that Dr. Sullivan will speak a bit as we go through. Now, knowing how much you've already given to us, and we've asked for a lot, we will be back at you again. We will be looking to conduct an initial survey of the financial health of our provider network and the effect of our DSRIP projects on our participating providers financially. We will also be establishing shared accountability models and looking towards down the road value-based contracts. We'll also be looking to have conversations with local managed care organizations of those contracts. So those are all in the very early stages of discussion. With the workforce, we have yet to conduct an extensive gap analysis in current state. We need to work with our selected vendor, 1199, on our policy training and redeployment efforts that will be occasioned by the implementation of the project. Some of these things are yet to be defined because until we really do detailed implementation plans, we won't really know specifically what's going to happen in terms of workforce. So after workforce, cultural competency, this is something that cuts across every single thing that we do. We have identified through our CNA challenges and priority groups. We've also done targeted hotspotting, but we need to continue to engage the community members in identifying challenges as we move along the path to transformation. We're also looking at a variety of different tools to enable patients and their providers to manage their own health care and to conduct, assessments in tandem with the providers, see how they're doing, knowing their numbers, et cetera, et cetera. Of course, again, back to workforce, we will be training the healthcare workforce in specific population needs as determined by our new approach to population health management. And that's, after all, what DSRIP is all about. So with that, I'm going to turn it over to Dr. Sullivan, who's going to outline for us some common elements across all projects, and then go through some other things that are absolutely important and cross-cutting. So, Jessie?
Thank you, June. Good morning, everyone. So, in addition to the 4 key elements that cut across all projects, there are some other common implementation elements that impact every single one of the projects, and this is a good a list of most of those cross-cutting common elements. So we need evidence-based protocols to run, set underneath what that we'll need to be doing. We need contracts and BA agreements. We need to implement a lot of IT that facilitates the projects. We have to have care management, the system. We need to coordinate care, and we're going to have to be very good at performance reporting, and cultural competence has already been mentioned. So we're going to go through each one of these, but we're just going to talk about a couple examples. So on the next slide, we're talking about health information exchange. And the key element of health information exchange for us is going to be connecting to the QE. The QE stands for Qualified Health IT Entity, and that is the new name in New York for what we used to call a RIO, Regional Health Information Exchange. And in our area, we're actually quite fortunate that there is just one. Think RIO merged with HealthLink of Southern Here to form HealthLink New York. And some of the things we're going to have to do is to connect everyone to the QE. And what it means to be connected is going to vary a little bit depending on your role. So for a community-based organization, being connected means you have access to the pool, and exactly what kind of access a community-based organization would have, this and the QEs are still kind of trying to work out, but some of our coordination is going to require that. For medical providers, behavioral health providers, for health homes, there's going to be a high level of commitment that there's an ability to do bidirectional exchange, to get some alerts and to do secure messaging between providers. And then for some providers, particularly medical providers, there's a higher requirement that the EHR meets meaningful use, and that includes doing exchange through the RIO. Next slide. This talks about care management, and similar to the connection to the health information exchange, there's just it's going to mean different things for different partners. So one of the most basic things about care coordination is we're going to be working on closing the loops of referrals. So that's all kinds of referrals, not just referrals from prior to specialists, but post-discharge referrals back to primary care. And the part that's really going to change things and be quite different than what's gone before is referrals to community-based services that aren't necessarily clinical services. And we're going to work on developing some platforms to allow that to happen. The next level is patients who will have direct face-to-face contact with some kind of care navigators. And we're thinking that many of these will be associated with care, where they will help physicians to pay attention to closing gaps in care and linking patients to services, both clinical and non-clinical. And then for the most complex patients, we have links with the health homes in the who provide comprehensive care and care coordination services for those patients who are eligible. And the things we need to do is to make sure that we have created good links and communications between the health home and all of the providers throughout our PPS. Slide. What they have to do is all kinds of performance reporting. And the performance reporting takes roughly 3 forms. So we're going to have to report a lot of process milestones, and we'll get into some of those a little later. And those process milestones are going to be reflected in the contracts that we're going to assign within the PPS organization. One example is just that we have to have meeting minutes for a number of different kinds of meetings. We're going to have to show that we have evidence-based protocols and that we're following them. We're going to need to find a way to collect data on clinical services that have been provided. So So as you know, the PPS is not the payer. You'll be billing the state or the managed care plan as you always have, and yet somehow we have to know that those services occurred. So we're going to have to find ways of collecting of clinical services that were billed to us, and we're also going to have to collect evidence of clinical services that aren't billable. So, for example, an asthma action plan. And the last thing is non-clinical touches. So a peer encounters some crisis situation and makes a referral to a health home. That's not a billable service, but it's something that we have to know that as part of the PPS that happened. In our patient activation project, we meet an uninsured person on the street, refer them to a food bank. They go to the food bank. As part of what we did, we need to be able to record that happened. So we're going to have to establish platforms for all of these kinds of reporting. Okay, so we have about 5 slides here, and I'm going to just admit up front that I brought these excellent. I've changed, but brought the ideas for these slides from Health Catalyst, which is one of vendors in the space of population health management. The next slide. I just want to talk a little bit about our approach to population health management. We're looking that there are 3 components that we need to do. We need to have content, we have a measurement system, and we need to have a deployment system. So talk about all these 3 things. And the deployment system is what state is measuring us on for the most part. Our deliverables are in the deployment system part for the most part, but we have the others to make it work. So next slide. So the content system, what does that mean? Well, the content system is what is it we should be doing. And I think all of these things are things we're going to want to do as we mature, because to be a successful integrated delivery system that's able to for value-based purchasing, we're going to need to be good at all of these things to succeed. But we're kind of starting at the bottom, and that's because the state has already given us a bunch of deliverables and a bunch of measures that we have to start with. And so the first thing we need to do is to put in place the protocols for those deliverables. And then we're going to build a learning organization. We'll come back around to doing these other kinds of things because the content is obviously constantly evolving in a learning organization. So the next slide. So content tells us what we should be doing. Then we need an analytics system to support the question of who should do it, for which question, where. So we need to identify populations of patients. We need to identify which providers are the providers taking care of those patients. We need to identify hotspots. And all of this is going to require analytics underpinning that is to be best in class to do this. Next slide. We need a deployment system. So it's okay to know what you should do and know who you do it for, but if you don't have a way to get it done, you're not going to succeed. All of these things are things we need to do, and I think that our 4 key elements: we need governance, we need financial sustainability, we need cultural competency, we need to address workforce, we need to be a learning organization that does training and learns over time. We need to build the infrastructure that will allow us to carry out the things that we're going to do. So this is also okay. So that's a little bit about sort of how we're looking at this and what we're intending to build. And now we're going to talk briefly about how it would look in our projects.
And the effects on implementation.
Well, all of this is how we're doing implementation, right? So, these are projects. I'm not going to read through them. Next slide. So, decks that we're going to send out at the end of the day are 11 slides, 1 for each project, and I am not going to walk through them all. We're going to go through a tiny bit on this one, and we're going to go through one other, but they're in the deck that you'll receive because these are the key deliverables that we have to the state around each of these projects. The one thing in the left-hand side, you'll see a box that says total committed, and it lists a bunch of different kinds of healthcare providers. Categories of healthcare providers given to us by the state of New York. So the state of New York took 3 MPI numbers that we or any other PPS submitted and put in one of these categories. And in every case, we don't necessarily, in some cases, we don't necessarily agree with the category that people were put, or organizations were put in, but this is from the state. This is the total number of these kinds of providers in our PPS network as we submitted it. So this is the total network, and the total network will be involved in the integrated delivery system. And as we go through some of the other slides, that for each project, the state decided which section of the delivery system they thought should be involved in that project. Now, we know that sometimes we're going to involve people that they didn't say, but we committed to a portion of the network per the state selection. So, Brenda, if you can find it, we're going to go through asthma, which is slide 30. So you can kind of just talk through. Oh, clever. You were ready for me. Okay, so we're going to walk through asthma. Asthma is the simplest of our projects. So on the left, again, you'll see the network that we need to involve. So we need to involve 524 primary care physicians, 100 practitioners who are not PCPs, so that includes physicians, but it also includes audiologists and social workers and speech therapists. We will need to involve 15 clinics, 27 health home care management agencies, that's all of the agencies in our network. 4 pharmacists, that's all the pharmacists in our network. We'll certainly have contact with all kinds of other pharmacists, but those are the pharmacists in our network. 35 community-based organizations, and 455 that the state categorized as all others. So those are the numbers of practitioners we need to involve in this project in order to meet our deliverables. And if we don't meet our deliverables, we don't get any money for the asthma project. And all of the money comes in through the project. So we need to meet these deliverables. So what does it mean to meet the deliverables? So there are 3 classes of deliverables, basically. There are what the state calls Domain 1 requirements, which I'll talk about in a minute. There are activated patient deliverables, and there are pay for reporting and pay for performance metrics. We're talking about the last 2 today. The implementation plan does not address those. We're certainly going to address them, but the implementation plan asks us to address how we're going to meet the Domain 1 requirements and the activated pay. So that's what we're talking about today. Application, we committed to meeting all of the Domain 1 requirements for asthma project by December of 2016. So what does that mean? Because we put all the detail on the slide, we've picked here just 2 of the 5 requirements for this measure, but we're going to give you a link where you can go online and see what all the requirements are for each of the projects. So 2 of these requirements are establish agreements to adhere to national guidelines for asthma management and protocols for access to asthma specialists, including health information exchange, connectivity, and telemedicine, and deliver educational activities addressing asthma management to participating PCPs. You may think, as I did, okay, pretty clear what it means for primary care practices to do these things, but what does it mean, for example, for a gynecologist in the asthma project to do these things? But we have 800 non-PCPs in this project, and we don't have that many pulmonologists and allergists. So we have to think, how are other practitioners going to participate? How are behavioral health practitioners, or no, I'm sorry, they're not up here. How are community-based organizations going to participate? So ecologists might participate in the asthma project by displaying in the waiting room about the importance of secondhand smoke and the impact of that on children, and actively asking patients who smoke about asthma symptoms and referring them to their primary care doctor. So for each project, we're going to look at each of the Domain 1 requirements and think, how does that requirement apply to each type of operator that's put in the project by the state? you'll notice that in this particular project, the state did not include hospitals in one of the providers, but hospitals and emergency rooms are extremely important in the management of asthma. So we expect to engage hospitals and emergency rooms in asthma, even though they're listed as a participant by the state. So in a single slide, you can go through, you can see what kind of provider types are involved. You can see a sample of what the project Domain 1 requirements are. You can go to the website and look at all the requirements. But that's what to do the implementation plan. We're now thinking how to get all these requirements done and how does each requirement pertain to each type of provider. So then the last part we're going to talk about is an activated patient. And for each project, we're still there. Yep. So for each project, there is a definition of an activated patient. And for asthma, the definition of an activated patient is the number of participating patients with an asthma action plan. So we know that's the standard of care. We think that it's being done extensively. But for to meet our requirements, we have to document among patients attributed to us that we have asthma action plans for those patients, current asthma action plans, and we've committed to a certain pace of getting that done. So the pace is that at the end, our ultimate goal is to have asthma action plans for 6,800 patients a year, but by June 30th of this year, we need to have 500. And while I think that there probably are already 500 in our PPS with asthma who have asthma action plans, that doesn't mean the PPS has the data about those patients having asthma action plans. And so between the middle of April, when we finally sort of get some funds and we're going, and the end of June, we have to have collected that much data. And if you go through the slide set, you'll see for each project, there's data we need that we're going to have 60 days to get. So we're going to be really paying attention to how do we document activated patients most efficiently quickly.
The other thing I'd like to add here, Jessie, is that we recognize that pulling the data could be onerous for some people in our provider network, and we will be sure to provide whatever resources are necessary in order to pull the data. So that might be that we send somebody in to do chart reviews or whatever other mechanisms we can figure out. But we are not expecting this to occur in the absence of resources to do it.
Right. I'm basically choose a chart review, as we all know. That is that will be our last resort, right? It's disruptive for you and expensive for us, but that's true. We will do it. But one of the most immediate things we're going to be talking about is for the particular things we need, what is the most efficient way we can gather that information, least onerous to you, least onerous to us, and absolutely we will provide the supports that we need to. And chart review is the last route. Next slide. This is the link where you can see this is the state's link, where you can see the scoring from all the PPSs, you can see the projects submitted, and you can also see the Domain 1 metrics for each of the projects in their full, gory detail. Next slide, and then next slide. This is just then to sort of summarize, this is, how the projects, for every project, every committed provider type is going to have some responsibility, but the roles are going to be different for different types of providers within each project. So we already talked about asthma. For primary care hospitals, pulmonologists, they're basically going to be delivering the care and the deliverables for that project, but other kinds of providers are going to be playing a supporting role. And there's a good anecdote some of you might have heard me say before about in another state that introduced the DSRIP plan. One of the gains that they had was by behavioral health providers a way of asthma treatment for patients with anxiety disorders, because the medicines that when you use the wrong medicine for asthma, the medicine can induce an anxiety attack. And so patients would use the wrong medicine and go to the emergency room with an acute anxiety attack be hospitalized for the anxiety attack. And having behavioral health providers better educated about asthma management, they were able to help patients to understand why they needed to use their other medicine instead of the one that made them anxious, and they saw some improvement in ERs and admit there. So that's just an example of how different roles can support a project. For health crisis stabilization, obviously the core is going to be behavioral health providers, community-based organizations, and hospitals, but primary care will have a supporting role to play. Patient activation is uninsured and non-utilizing and low-utilizing Medicaid beneficiaries, and that's going to be primarily the CEOs and the FQHCs, but certainly we're going to involve every member of our PPS in some way in knowing that that's happening and how to be supportive. Transitional care after hospitalization, the primary participants are hospitals, homes, and primary care, nursing homes when people go to nursing home. But it's important. Sometimes the thing that's going to keep someone from going back into the hospital is care delivered somewhere else, including it can be community-based care that could make a difference. And then finally, for tobacco cessation, those who are able to bill for tobacco cessation under state rules are PCPs, specialists in behavioral health, but we expect everyone to play a role in promoting tobacco cessation. That's just an example of how the roles will look different for different projects. So we're on time, okay.
So Peg is going to talk to us about assessments of PPS readiness.
Hi, everyone. I think Jesse did a great job going over everything that's in play and what we need to do. And this really talks about the 4 key elements, which really we spoke about before. But we'll be getting back to you, we hope, in a least onerous way to get more information about IT readiness. We did collect some information in the fall, but we know we're going to need to update that with financial information, employment data, and really your workforce strategy and future needs. We can anticipate and we can guess some of that, but we want to really check in with you and make sure we have the most current thinking information on that. Population served, I think that's an area that I know there's a lot of specialization that providers have that we need to make sure we've captured that. We're not sure we have all that. I know there's some real granular data, best practices about cultural competency, special populations. So we really want to make sure we're doing all that. And ultimately, yes, this goes into our provider contracting, how funds will flow, and value-based contracts that we do have in process now. And if you haven't been contacted by our provider relations staff, we wish you to do that. And this is about primary care, trying to get so much more information from providers, things like hours, sites, ER, all the kinds of things that we really need. And primary care is so cross-cutting across all of our projects that we need to make sure we really have all that information. So stay tuned. We will be requesting more from you. Then we want to just briefly go over where some upcoming meetings that we're going to be having. And on March 12th, we're going to have a meeting with those providers that showed an interest and actually gave us some data in the fall about integration of primary care and behavioral health. That's going to be on March 12th. If the primary care providers that are interested that didn't respond previously, please be in contact with us. We're going to have, Jesse's going to be holding a primary care physician webinar. Let it go out, and hopefully everyone has received it. Again,
there's a typo, I'm sorry. So it's 5:30 to 6:30 p.m. on March 10th or 8 a.m. On the 11th, and it's the same content for both. It's just we're having the same webinar 2 different times to try and make it convenient for people to catch it. So either the evening of the 10th or the morning of the 11th.
That's great.
Sorry, I didn't see that before.
Okay. Having our PAC workforce, again, workforce is one of keys to all of the PPS projects. And that meeting is going to be on March 10th. That's chaired by Deborah Marshall from Monsecore and 1199. We have CSEA representation, folks that represent education, training, related to workforce. Next PAC executive meeting, March 10th again. And on March 6th, we're having a Hudson Regional Officers meeting, and that's with the commissioners and the directors of the Department of Health, Mental Health, and Department of Social Services. And that's an opportunity for us to give them more in-depth information about what we're doing. We have had a lot of communication with them on our projects, and this is a way for us to answer any questions and we get their feedback and ideas about some of our approaches.
I'd just say one thing, Peg, here. This is June here. Just so he understands, the implementation plan doesn't mean that we've gone and conducted the work to be done before filing it with the state. The implementation plan is the work plan by which we organize and accomplish the work in the different project areas. So I don't want people to feel that we're running ahead and doing all of this stuff in great detail without consulting with the various work groups and other stakeholders. We're not. The work plan is the implementation plan is the work plan, and it parses out the various projects in lots and lots of excruciating detail as to work steps and timelines. So that is why you will see it as part of our implementation plan, which will also be open to the public once it goes in. You will also see that a big part of the work plan are the work group meetings that pertain to the various activities and employments that will happen here. So just wanted to point that out.
Great.
Thanks, Peg.
This is Deborah Viola. That's a good segue because the implementation plan that we're submitting is about the work groups and workflows and processes that we'll be establishing. So Brenda, if you could move us forward. Next. So essentially we're submitting to the state that yes, we'll meet the deliverables and targets that you've given us by bringing groups of people together, subject matter professionals, and sharing best practices. In fact, pulling together deployment teams, as Jesse described earlier. And so we hear a great opportunity for all of you to help us move forward our commitment to being a learning organization. We think about a way of facilitating this process and how we could take groups that we form not only within our own PPS, but continue collaboration with the other PPSs in our region. And one concept that we are right now in the process of trialing is establishing these individual groups using mixed platform that the state has made available to us. So for example, we can take one of our projects, tobacco cessation, that is part of a public health council that connects all 3 PPSs in our region, and will, moving forward, connect us with our community-based partners and public health folks in the various departments of health, mental health, social services, and how we share best practices, more about the populations that we'll be working with so that we can assure cultural competency and sensitivity and health literacy. And so go to the next slide, Brenda. I can give you an example of this first group that we've set up, the Hudson Region DSRIP Public Health Council discussion group. This one is going to be focused on tobacco cessation. And you can see under latest activity that we've got our medical directors participating from our PPSs in the region, Amanda Parsons from Montefiore, Jesse Sullivan from Westchester Medical Center. We have participation from our colleagues at Refuah Health Center. And what's about this platform is that we can invite folks who are part of this group. So when they come into this, they'll see our homepage, a group listed that they have just on their own login and ID. We can open this up to others as we expand. What this requires, though, for you folks to get involved with us is that you must have a login to be mixed. So on the prior screen, I've got that link for you. It's really straightforward and simple. And if you haven't visited already, you'll see a lot of other great groups and initiatives and challenges. What this will also allow us to do, for example, on tobacco cessation, there are some issues that we feel are state level, and we'll be able to post challenges that we can open up to all of the PPSs across the state. So stay tuned. We will be giving more information about these various groups as they become established. But in the meantime, if you can think about areas where you'd like to participate, feel free to go on our own website, send us an email, and let us know. So we are going to be opening up to questions, but before we do so, I just want to thank everyone for hanging in there with us. Once again, helping us carry that heavy load towards the finish line. And we welcome and look forward to really working with you after April 1st.
Yes, I'd just say, actually, I would correct everyone only slightly. What you're helping us do is the start line.
Right. Okay. Right.
We're actually, the real work begins April 1st,
yes.
And we look forward to working with all of you, and we thank you for all the work you've done to date. But I hope you understand, as we do, that this was the easy part. And now the real work begins, because now we're actually going to try to affect the care that patients receive and improve that care. So looking forward to that, as I know all of you are. So with that, I'd like to open it up for questions. Brenda, if you could tell people how to move with that.
Since we have over 100 participants, we're going to ask that people use chat function to send questions to Keir Wallace, the host. That's actually me, but I'm using my colleague Keir's login here. But if you could just type up any questions. We would open the phone lines, but it's hard to do with over 100 participants, so I appreciate your patience on that. While people are typing in questions, I just sent out a note, but just to remind everybody, yes, the full slide presentation, including those slides on the individual projects that Dr. Sullivan referenced but didn't walk through, will be made available after this webinar, so you will have access to the slide deck. One question, Dr. Sullivan, I think you addressed it on slide 33, but since it was raised, I'd like to go back to it. Just a concern raised about the absence of behavioral health providers as a primary participant in the asthma program, and I think that's sort of a tension points that you talk a lot about, the report requirements that we have to be sensitive to, and then what we're going to actually do to be successful in a project. But if you could address a concern that behavioral health providers were not listed as a primary care provider in the or a primary participant in the asthma program slide.
Right. Well, yeah, behavioral health isn't listed, and neither are hospitals. So I think there's two things. So
that wasn't what we did. That was how the state.
The state did it. Right. It wasn't how we did it. So we're going to have to think about how we're going to need to get it done for patients, and so we're going to have to involve whoever we really need to involve. And I think my first line strategy is going to be, so the state has a category called all other, but then who they thought fit in all other. I think my first strategy is going to be, we're going to get everyone to participate who we think should participate. I talked about behavioral health in hospitals for asthma, and we'll call them all other, since the state didn't include them in that project. And the state won't let us count them, in which case we'll have to involve behavioral health and hospitals in asthma care, and we won't, in a sense, get credit for it in the deliverables. But we're going to have to do what we have to do to take care of patients. So I just think that and project by project, that's so. Do we have a pause? I wanted to also underscore what Deborah said about, your passion. And I would very much love to receive emails from people who to participate in some of the work groups that we're going to have to form. So we're going to have different levels of clinical governance. There's going to be this regional quality council that's a joint thing between the 3 PPSs in the region. They're just going to be looking at some basic components for protocols that would be the the requirements for what we've established within each of our PPSs. We're going to have some local-based clinical deployment teams taking into account sort of the local conditions. So lots of different ways for people to participate. And I'd love to hear from people who are passionate about something particular.
A question to Viola. Can you talk a little bit more about the Hudson Valley Regional Health Officers meeting? Is it an in-person meeting? What is the role of the health departments? What is the purpose of the meeting? Who can attend? Can you talk a little bit more about that?
Oh, definitely. So although we sent invitations out directly to the county commissioners in those three areas, and Dr. Amler, Shalita Amler, is doing this for us and sent an invite as well. If anyone is interested in attending and thinks that it would be a good information session for them, you can send us an email and let us know. You're welcome. It will be again on the campus of the New York Medical College. And we can send you directions. What we'll be doing that day is covering essentially some of the same information that we've covered here at this PAC meeting. In addition, we'll share very briefly some of the results of the survey, which we will also be posting on our center's website. We did collect 1,777 responses, which meant we did have a nice representative sampling of individuals who live in our county. And so we know that especially the Department of Health folks who had helped us with that would probably to get some feedback on how that went. We'll be discussing, Amanda Parsons will be there to discuss the Hudson Region DSRIP Public Health Council and how we can involve the various county departments in the tobacco cessation effort. This will be one of our first groups where we'll be working towards this type of collaboration.
Do we have CSS and OMH?
Again, the invitations went out to the commissioners of mental health, of social services, and of the Department of Health, the public health. So again, please, any questions, you can send them directly to me. If you'd like to attend and didn't get the invite, please let me know, and we'll get the information out to you. And I think I covered it. Yeah.
A question I'll ask broadly. Have you developed a plan yet to allow safety net providers that do not have EHRs to participate? And how are we thinking about connecting those that may not have an EHR by the time DSRIP really gets rolling?
That's part of, so figuring out what status of everyone's HIT is one of the questions we need to do. So we need to collect information, and HIT is health information technology is absolutely one of the pieces of status we need to collect. So I think we sort of have to have a picture of what that status is before we formulate the plan for how we're going to address it. So clearly it's something we're going to have to address, but until we know what the deal is, I think we're not ready to say how we'll do it.
We have questions coming in from individual organizations that are interested in getting involved and want to understand across multiple provider types where you see their role, what projects they can participate in, how they get involved in the work groups exactly, where they email information about their passion. We're going to collect all of these. I think it might be easier as one provider types to follow up with folks because there's some very specific granular questions, but maybe we could talk a little bit more about the process of getting involved and who exactly to contact.
Right. So it's easy for us if the emails go to the CHI website, because we make sure that they get farmed out to someone if I'm out, or so that we have a record of them, and so that's great to respond to our email address. And, I think I just want to say a little bit, because I think this is part of the question about participating in projects. And some other PPSs have gone out and asked practices and groups which projects they want to participate in. And our thinking has been that the state has said to us that we get a certain number of each kind of provider. And so We have to get those numbers. And so I kind of think if a project applies to you, you join our PPS, we're expecting you're going to do your part. So when I said participate, I mean like, so everyone has to do something, whatever it is, get asthma action plan for every kid with asthma. But some people, that's their passion, and they really want to be involved in the groups that are thinking about it and developing the measures and doing the evaluation cycles and really guiding that project. And people, that may not be the thing that, really excites you. And if you're in primary care, you're going to do it anyway, and you are excited about something else. So we're really asking for where do you really want to have some input in our thinking around it. But I kind of think we're going to have, people are going to have to do what the state says we have to do.
I guess a way of saying, if you signed up to be a provider in our network and you gave us an attestation, going in assumption is that you will participate in all relevant projects.
They do, we did a lot of work on the application based on the information that we had that was growing and developing, because this is a new project for the state as well. It's a new effort in the country. Nobody's ever done a Medicaid reform initiative quite like this. And as we're going through the implementation plan, which is really a structure of our reporting to the state on specific milestones, we're getting more information and learning, and the CHRI team has been deeply involved in thinking through how these programs will really be actualized and implemented. So part of the next couple of months will be a little bit of patience and a lot of collaboration while we figure this out. And it's good to keep raising these questions. There just may not be answers exactly to all of them yet, but there will be. You're working through it. I have a question. This has come up before, but I think it's an important one to raise again, is there are providers in the Hudson Valley that are participating in more than one DSRIP effort, sometimes with overlapping projects. Have we thought at all about the workflow and the separate processes for collecting information and how the PPSs will coordinate?
Right. So we've actually already had a couple of preliminary meetings of the cross PPS committees, and there are 3 cross PPS committees. There's a leadership committee, an administrative leadership committee, and there is a clinical council, the public health council. So Deborah spoke about the public health council, and I spoke briefly about the clinical council, and Tony participated in the leadership administrative coordination. And then for the behavioral health project, behavioral health crisis project, we have already established a PPS work group that's
right. Yes, Montefiore, ourselves, and Rafula are meeting in a number of communities on the crisis project to make sure that we're all together in approaching them the same way. It would make absolutely no sense to have duplication of effort in that arena.
So let me just say the other thing about the Regional Quality Council that I think is very relevant to our provider networks, those that are common, we will strive where possible to have similar reporting requests and requirements so that we're not asking providers to keep sets of books or to be reporting differently to our PPS and other PPS.
So that actually a critical part of that is having a common data definition, so that
right.
when we ask or Montefiore asks for a specific element, we both mean the same thing.
Exactly.
We may have somewhat different report requirements just given the nature of our organizations, but we want to have a common dictionary, if you will,
right.
so that we don't actually ask when we use a set of words, we all mean the same thing.
Right. Well, so I totally agree that that's the goal, and so absolutely that's the goal. Given the timeline that we have, so we have like 60 days to collect a bunch of data, and if we went through a harmonizing process with all 3 PPSs around the definitions, we wouldn't have finished the harmonizing process by the end of 60 days, let alone.
Right.
So I think part of it is going to be we're each going to go out and tell you what we need, and part of it is going to have to be so it's understanding that there is the intent on part of the PPSs to harmonize and make it work, but we all have these very fast deliverables. So part of it is going to have to be feedback from the provider network that says, you know, you asked for it this way, they asked for it this way, couldn't you, you know, because, and knowing that we want to do that, yeah.
Understand that some of these goals are aspirational and may not hit them day one.
Day one, right, exactly, right.
And then again, we're still getting a number of comments. They're very helpful. Please continue to send them if you'd like, about individual organizations and what provider types they are, what patients they serve, asking how they can get involved. So again, I will collect those and send them to the CHRI team, and I think it'll be easier to address those questions one-off rather than on a group call. But if there are any other open questions, please submit those now. We'll give it kind of one more minute. Otherwise, I think we might be wrapping up here, team.
What Brenda sent me an email on this is when we send this deck out, before we send it out, we'll have a slide and we'll clearly have our CRHI website where you click to send us an email, and then what you need to put in the header so that we're sure it comes to us, and so that will make it a little bit clearer for you and easier.
Looks like, where will the recording of the session and the slides be available? Mario, I think, will send out an email through the newsletter distribution, and then the materials, I think, will be available through the CHRI website. Is that correct?
Yes. Yes. Yeah.
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 We'll post it today.
Yeah, it'll be this afternoon. I just want to add in that slide to make it clear, and we'll change that meeting date to AM for those who see it and weren't listening. Might show up pretty late at night. I don't want to do that to anybody.
Okay. So I'll leave the comments open just for another minute because more people are sending information about their provider type. So I'll just leave this running for a few more minutes, but I think that wraps up the general questions, and I'll turn it over to you for closing comments.
Okay, so this is Tony Muller again. Thank you, everybody, for your participation. As I say, we're approaching the starting line. We're looking forward to what we believe is going to be very challenging but very successful and meaningful work over the next 5 years. We look forward to working with all of you, and please continue to provide your feedback, provide your comments, provide your questions to the CRHI team. We can make this work as well as possible, both for you and for us, and for, most importantly, for all the patients that we collectively serve. Thanks.
Thank you.